Hi, my name is Manesh Patel, and I'm joined by a friend and colleague, Mike Gibson, as we talk about practical considerations on how factor 11A inhibitors fit into stroke prevention. Thanks for joining me, Mike.
Good to be back, Manoj.
Awesome. Well, let's get into it. Where are we now with our practice and where are we going? It's a common thought for a lot of the things we do for stroke prevention, but also just parts of medicine. I'll start by saying DOACs have improved anticoagulation across a broad spectrum with many more patients getting therapy for atrial fibrillation, but bleeding concerns still persist. And stroke prevention in AFib remains under-optimized, I'll say. Greater than 1 in 3 are high-risk patients are not treated appropriately, and there's plenty of clinical inertia, bleeding risk, renal clearance, adherence, other issues that prevent us from getting patients the therapy they need. There's a variety of decision support that we have, as we've talked about, and many more really interesting versions coming. So the decision support on the sort of, I'll say 2 or 3 things. First is, should this person be treated? And what we know is a majority of our patients at risk likely should be treated, although there are some that remain at high risk, at high bleeding risk, at high residual stroke risk, even after therapy that we can talk about. And then the choice of anticoagulant with ongoing monitoring, ensuring that their own caretakers and our health system is continuing with that. And then the management through procedures in life, going through life where you scrape yourself or you have to have a dental extraction or you have a cholecystectomy or a colonoscopy or a cath. DOACs and others are going to have to be managed through that. So that's the process of where we are with this practice. And, the practical risk mitigation is often to confirm that the person can get the therapy. That's often a payment and an opportunity to get access. Address proactively, making sure that they understand the reasons we're using the therapy, the risks and benefits, and the way we're tailoring their safety strategies, including reducing other antiplatelets or other things that might increase bleeding, and minimizing that the best bleeding risk by, as I said, dose reduction, not always dosing correctly, but dose reduction appropriately, and then drug-drug interactions. Currently, the ACC/AHA guidelines refine the approach to atrial fibrillation management in sort of 3 big buckets. One is proactive risk factor management. Before we think about atrial fibrillation anticoagulation, as we sort of talked about in our practice, in many ways, it's guideline-directed medical therapy for the risks that patients have: blood pressure, cholesterol, diabetes, other things that might make the person's lifestyle-associated risks higher, sleep apnea, et cetera. The second is the impact across the AF spectrum. So evidence supports addressing these risk factors to reduce the burden and whether the person's in paroxysmal, persistent, or permanent AFib. And then team-based care to manage and closely coordinate with cardiologists, pharmacists, primary care providers, the things that we're doing to reduce their risk for AFib and AFib-associated complications. So our stepwise risk management approach is first to confirm the diagnosis. Despite getting a variety of wearables, we still often need an ECG or a rhythm strip or something that shows us the validated atrial fibrillation before initiating therapy. We then assess their stroke risk. Most commonly, this is done with the CHADS-VASc guideline recommended, but other risk scores are available too, with shared decision-making, as we've said, critical in making sure they understand their risk, we understand their sort of their wants, beliefs, and principles of what they want, and then we give them our best recommendation. Modifiable risk factors, and so identifying them and then modifying them, and that includes, like I said, sleep apnea, alcohol use, hypertension, and then we usually use a strategy to manage both their symptoms, their comorbidities, and their risk for stroke, tying in their preferences and their beliefs and their sort of variables of life that they care most about. So we've talked about a balance beam. That might be a good way of thinking about it compared to a seesaw, because the seesaw makes it feel like they're always opposed to each other, whereas as Mike, you and I have talked about, a balance beam feels like you're going forward in life and you're trying not to sway one way or the other. But there's a balance between clotting, that's good clotting to prevent stroke, and preventing bad clotting that may be bleeding. So the bad clots have this risk factor called CHADS-VASc. And interestingly, the guidelines don't recommend doing a has-bled risk factor score. They just recommend at least understanding the modifiable features, although previously they had a has-bled. They don't recommend that now. And I agree with that, since the clinical trials didn't have everyone get a CHADS-2 score and then a has-bled. They just started people on therapy and modified their risk. And on the bleeding risk, that's medical adherence to the therapy, preventing other risks for bleeding, and then making sure family and others are engaged. So in this whole pathway, where do factor 11A inhibitors fit into stroke prevention, and who are the appropriate patients? One way to think about this is patients with atrial fibrillation that are high risk for stroke need therapy. And those that are expected to tolerate the therapy well, be on the therapy for a long time, and not have side effects, most notably, I shouldn't even call it side effects, the untoward effects of bleeding. Then on the left side of this pathway, we might think about are people who are expected to tolerate anticoagulants, and they should get DOACs, probably and preferentially over vitamin K antagonists if they have access to it. On the right side, I would think are people who have residual bleeding risk, people who cannot tolerate the therapy, people who may still have stroke risk. These include people that are elderly. The stroke might be related to prior ICH. They may have hemorrhagic risks in their brain. Those are patients that are potentially our best candidates for factor 11 inhibition, certainly with factor 11 inhibitors, such as factor 11A inhibitors. And these are patients with elevated bleeding risk, vulnerable high-risk patients that may not be candidates, and then patients who might have had prior bleeding, especially bleeding into the brain. How can we reduce the bleeding risk in anticoagulated patients? We've sort of talked about that. That's to eliminate or minimize concurrent medications, avoid aspirin, NSAIDs. For certainly those patients, it's not indicated. We've even had randomized trials with the DOACs that have shown chronic DOAC use in CAD patients where you drop the aspirin and just use the DOAC has demonstrated preferentially better outcomes in patients with atrial fibrillation and coronary artery disease in whom chronically we drop the aspirin. So stop aspirin in patients with chronic CAD. And those post-PCI, we have several trials, some of which Mike led, where we can go through what the dosing regimen should be and the strategy for going from DOAC plus DAPT to DOAC plus one antiplatelet. I think that's a strategy that is commonly used and would be one you would use. And most importantly, avoid underdosing. Use the evidence-based dose if you can, because it doesn't lower bleeding risk and it certainly doesn't protect them for stroke. Now, many people say, what are our best strategies for preventing bleeding on anticoagulation? So the first is, ensuring the antiplatelet need or not. That's the first common one that I've talked about already. Does this patient have to be on an antiplatelet agent? The next is to assess and manage comorbidities that could contribute to bleeding, thrombocytopenia, anemia, peptic ulcer disease, uncontrolled hypertension. Are there things there you can do? Assess modifiable lifestyle factors, alcohol use, herbal products, NSAIDs, all kinds of other vitamins and things. And people say, well, Manesh, they're not going to make you bleed. I go, well, it leads to confusion. If you're taking 10 pills and you don't have evidence for 4 of them, and you're asking for an evidence-based therapy, you should think about what that polypharmacy does to the patient. Now, I'm not saying die on the hill of getting your patient to stop their vitamin. I'm just saying if they're taking St. John's wort or other things, just highlighting for them some of those interactions that they can do. The next is to assess the anticoagulant for appropriate drug and dose. So making sure that we use the anticoagulant that's best for this patient at the right dose. And finally, looking at drug-drug interactions. This is something that we expect for all of our care, but it's quite a complicated 5-step process that we can imagine does take some time. And the drug-drug interactions we often think about are numerous and independently associated, increase with more drugs that the patient's on, as I've highlighted. This is where our pharmacy colleagues help us often. And there are common ones to think about, but the most important thing I'd say is that if you can reduce drugs in general, the drug-drug interactions go down. And that's why even for those therapeutics that seem non-consequential, the vitamin E or the fish oil tablet, I try to reduce those in my patients, including the NSAIDs, which clearly have a bleeding risk, and the antiplatelets, and then take a close look if they're on something that should, even if you're not sure they have an interaction, should make your spider sense tingle. If they're on an anti-epileptic therapy, then that should make you think, if they're on an antiretroviral, you should say, wait, those seem to go through some of these pathways that I'm going to have to think about. Obviously, if patients are on those things, our clinicians are often working with pharmacists, and our pharmacists are working on ways to do that. It's important to recognize that direct oral anticoagulants and AFib can increase the risk for both drug-drug interactions, along with the DOACs and AFib can increase the risk for both stroke and bleeding and increase hospitalization. So reducing these interactions are really important. Now, how about falls and bleeding? Another common conversation, right? My patient's falling a lot. I'm worried about their anticoagulation. I think in general, what we've said is before we think about the anticoagulation is just to think first about falls. How can you make the home safer for our elderly patients, which includes understanding their pathway around the house? Do they have a walker? Do they have actual things to help them move around? What's the footing surface? Do they have a lot of carpeting, a lot of different levels? And then what's going on often in the middle of the night? A lot of patients have to get up to go to the bathroom. They're near their bed. They don't have their walker. They have a rug. They have some obstacle in their way. And unfortunately, they fall on the way to the bathroom. An all too common story. So working through that with patients is important. Making sure they understand to sit before standing, to lightheadedness, and then obviously drinking and using NSAIDs and other things can obviously interact in ways that can really lead to increased bleeding. Now, why are we thinking about factor 11 inhibitors, especially factor 11A? Traditional anticoagulants target both thrombosis and hemostasis, and that leads to a bleeding risk. As we've discussed in many ways, factor 11 inhibitors aim to uncouple these two, inhibiting the bad clot, as Mike has said, thrombus formation, while preserving hemostasis, the good clot, preventing those things that might mucosally bleed. And if we can identify the right patients with the right populations to get these, we can maybe get a better, simple, standard efficacy in therapy. So our opportunity is to integrate into guidelines, and we see this, and I think this might be an important conversation, Mike, as we get into this, is that factor 11A inhibitors may enter the guidelines as alternatives to DOAC in specific populations, and we think those populations people should be thinking through are high-risk bleeding patients, patients with ICH or major bleeding, or elderly patients that are at risk for bleeding, especially people that have things like renal dysfunction. And future head-to-head trials will help us better understand the outcomes and guide the broader use that we see. Now, what is the current inhibitor landscape in stroke prevention, and what's the anticipated role in guidelines? Well, I'll just say there's a few ongoing studies that have occurred. We've talked some about existing ongoing trials. Librexia oceanic stroke are trials going on in patients that have had a recent stroke, not atrial fibrillation related, and they'll likely, as those get read out, will play a role in guidelines. And then the factor 11A inhibitors could serve as a preferred therapy in high-risk populations to bridge the gap for stroke prevention and minimizing bleeding risk in certain populations. Now, how would this help us with our provider concerns or the concerns we have in real world? Like, what do docs need to know? What do patients need to know? What does that lead to our practice? Well, I'll just say in all of these trials, the information's almost always going to be the same, which is we have to know long-term bleeding and stroke risk. We want to know, will they get covered? And then when I put it into my practice, does it respond like it did in the trial? And then the real practical questions are, how do I go on and off these therapies, and how can I use them in my practice when people are going in and out of procedures? And I think a lot of that will come out as we do these studies. And as we did in the prior DOAC data, Mike, to say this is where I think our opportunity exists. So I guess I'll ask you this question. In your current practice, when you're thinking about patients at high bleeding risk, such as those with ICH or renal impairment, how do you think about anticoagulation today, and what do you think the factor 11 inhibitors may shift in your thinking there for those patients?
Well, Manesh, we'd like to think we can separate bleeding risk from efficacy risk. Those two tend to go together. If you're a high bleeding risk patient, you're also a patient who's at high risk of ischemic events. So we can't really uncouple those two. I think at this point, the best we can do is probably a bit of dose modification of existing agents to match the dose for the patient and their risk. Again, I was surprised when I looked at the literature. We did deep dive on prior ICH and the benefits of possibly continuing anticoagulation, but we're very hesitant in those patients. I do think this new class of drugs might be a major advance if we can reduce that hesitancy for these high-risk patients and to actually treat them rather than avoid treating them.
Yeah, I think it's a great point, Mike, that, we have this sort of artificial version of what we think we can do, but I think the idea is to better understand how we can treat most of these patients and how we can get better for them. And I think that makes us move quite a bit forward. So I think the patients who may benefit and who are early candidates are those that, as we've highlighted, might be frail, have these risk factors that are preventing treatment right now, and could even go into earlier stages if the bleeding risk really gets demonstrated to be beneficial. I guess in conclusion, what I'd say is that your key takeaways for integrating factor 11 inhibitors into practice and what clinicians need to know today is there are ongoing studies that will help us do a personalized approach for our patients. And we think, given that risk benefit of our patients, that these therapies are going to be aimed at those high risk groups that currently are underserved due to bleeding concerns. Those elderly patients, those with prior bleeds, those with potentially renal dysfunction or other issues that prevent them from getting the therapy. And as Mike said, the practical integration is going to be sort of, you're not always able to identify those, but you're going to start to understand the data and make these, I'll call them patient preferences and shared decision making, and collaborating with your team will matter. So maybe we'll end by saying, another question, Mike, as we move into our case study discussion, how do you approach translating clinical data into real world treatment decisions for patients who don't fit neatly into guideline boxes?
Manesh, this is what we hear from practicing docs, the academic people in the ivory tower, you make these guidelines up based upon populations and the results from trials and populations, but none of my patients fit the guidelines. And, there's a little bit of truth to that. But that's where the art of medicine comes in. And, we're all kind of doing our own little human AI thing at any moment in time where we're integrating all the evidence and trying to make the best choice for the patient sitting in front of me right here, right now. And that's the art. But hopefully we'll have some better quantitative tools in the future. We'll replace or supplement art with AI, but it's still a lot of art there.
Yeah, thanks, Mike. I agree. A lot of this is going to be how do you apply what we are learning to practice? That is the art of medicine. That is, as you highlighted, the relationship of medicine, what we do with our patients to make sure they're with us. So thank you all for joining us as we've had a conversation about how to think about these factor 11A inhibitors and just overall stroke prevention in our patients.